So we are good to go.
Good evening, everyone. I, Dr. Aggarwal, on behalf of Emcure Pharmaceuticals, welcome you all to this scientific deliberation by Dr. M.B. Aggarwal sir on the topic evidence-based medicine of anemia during pregnancy with focus on ferric carboxymaltose. After an enlightening and a very informative session on diagnosis of anemia, we bring you the second webinar in this lecture series by Dr. M.B. Aggarwal sir. I take this opportunity and it is my honor and privilege to introduce you Professor Dr. M.B. Aggarwal sir. He is the head of the Department of Hematology at Bombay Hospital Institute of Medical Sciences, Mumbai. He is a senior consultant hematologist at Lilavati Hospital and Breach Candy Hospital. He is the president of Mumbai Hematology Group, Indian Society of Hematology and Transfusion Medicine. He has been a founder member and secretary of Thalassemia and Sickle Cell Society of Mumbai. He has been organizing secretary for annual national CME in hematology and hemato-oncology. He has a teaching experience of more than 30 years at undergraduate and postgraduate level, and he is a recipient of several fellowships, orations, lecturerships, and has received many awards at different levels. He has been invited as speaker and has conducted several workshops at various prestigious institutes in India and abroad. He has more than 130 articles to his credit in national and international journals and has authored 7 books. He is an emeritus editor for Indian Journal of Hematology, honorary editor for Indian Journal of Hematology, and editor for newsletter of Thalassemia and Sickle Cell Society of Bombay. We are honored to have you, sir, and I now request you to take the proceedings of this webinar further. Over to you, sir.
Thank you, Dr. Ajink, for that kind introduction, and good evening to one and all. We come to the second part of these 2 webinars organized by Emcure, and I thank Emcure for putting us together. Last week, we discussed about the diagnosis of anemia, especially iron deficiency anemia, and today we are going to talk about evidence-based management of anemia, especially during pregnancy, and we'll have a focus on FCM as the molecule for the treatment of anemia, that is iron deficiency anemia. So moving on with the treatment of this particular entity, that is iron deficiency anemia during pregnancy, is not just by using one tool. You can have various tools, and I like to divide this into 5 groups: the dietary advice, the oral iron therapy, intramuscular iron therapy, intravenous iron therapy, and the blood transfusion. Talking about the dietary advice, the very old advice could be cook your food in iron vessels and use rusted knives, and that should give you a lot of iron. Obviously, that is obsolete. Then you have iron-rich food during pregnancy. Now, can this be used to treat anemia? The answer is no. All dietary items, if they are rich in iron, can prevent iron deficiency anemia, but they are inadequate to treat iron deficiency anemia. However, we'll go over this. So from green leafy vegetables to fruits, to citrus fruits, to various kind of dry fruits, pulses, specially made food preparations during pregnancy, iron fortified chocolates. So you have got a variety of vegetarian items which can give you iron. One thing that should be avoided is to have a cup of tea or even coffee immediately after lunch and dinner. As we discussed last time, it interferes with the absorption of iron from the vegetarian food. And then you have animal sources, and almost all animal sources are quite rich in iron. There's a difference between absorption of iron derived from the plant source and from the animal source, and this you must remember. I don't have any interest in going through this slide as a whole, but as a student of hematology and of iron deficiency anemia, you have to know a few things: that iron is absorbed from duodenum. There is something called transferrin, which carries this iron to the bone marrow. Erythropoietin that is produced from the kidney is important aspect of formation of RBCs. This newly described molecule, erythroferron, is extremely important because it suppresses the hepcidin production from the liver, which is important for iron absorption. And lastly, the hepcidin itself, which blocks the iron absorption from the gut or its release from reticular endothelial system. This hepcidin is a wonderful molecule, and I'm sure that one day the discoverer of this molecule is going to get the Nobel Prize. Hepcidin is a 25 amino acid structure which is connected by 4 yellow disulfide bonds. It's produced from the liver. Its job is to control the iron absorption release from macrophages. So it blocks the absorption from the intestine. It blocks the release of iron from the macrophages. The job is that you should not get iron loaded in your body. You should not get infection because iron is food for the organisms. There is this particular molecule called ferroportin, which is sort of the only exit molecule for iron in the body. So iron goes into the blood from the intestine or is released from the macrophages with the help of this ferroportin, which is blocked by hepcidin. There are a couple of pictures over here, which I need not go into the details to describe all this activity of hepcidin, ferroportin, and absorption of iron. In short, if you consume mixed diet, probably you've got all sorts of iron available to you, and the chance of developing iron deficiency can be less. Unfortunately, the requirement of iron during the pregnancy is such that it can never be supplemented by iron, and everyone needs supplements. And now we'll discuss 3 types of supplements: the oral, intramuscular, and the intravenous. The oral iron available, there are a large number of molecules, and probably all of them are quite good. They work, they're cheap, they're effective. The problem is that the oral iron is full of side effects. It can upset your stomach, nausea, diarrhea, faintness, vomiting, dark stool, constipation. 1/3 of the women are very, very uncomfortable taking oral iron. And if you compare intravenous iron in the dark green and the oral iron in the light green, you will see that the bars of light green are taller than those of intravenous iron. It's the oral iron which causes a lot of nausea, which can cause a lot of constipation. It can cause diarrhea. It can cause abdominal pain, cause vomiting, and so on. So overall, oral iron therapy has to be reconsidered during pregnancy. 1/3 of the women report GI toxicity, especially worsening of constipation. Pregnant women are as such constipated because of the high progesterone, which slows the bowel movement. Also, the gravid uterus presses on the rectum. And on top of this, when you give oral iron, there may be no passage of motion, sometimes not only for days, but even for the weeks. And that can be very, very uncomfortable. That brings us to the parenteral iron, which can be either intramuscular or intravenous. For all practical purpose, intramuscular iron therapy is outdated and not used anymore. So we come to intravenous iron, which can be given either as slow bolus over 5 to 10 minutes, or more preferably, it is given as a short IV infusion. There are generations and generations of intravenous iron preparations, and they can be split into at least 3 generations. And if you want to understand what generation means, you see the 4 generations over here. The story of intravenous iron began almost about 100 years ago in 1932, when ferric hydroxide as a naked molecule was injected to human beings to boost their hemoglobin, and the result was 100% death. This made people realize that you cannot inject a naked molecule of iron, and it has to be coated with a sugar. And depending upon the type of sugar you use to coat the iron hydroxide, you've got iron saccharide, high molecular weight iron dextran, low molecular weight iron dextran, ferric gluconate, iron sucrose, FCM, the ferric carboxymaltose, and other molecules. So you see that after iron, there is name of one of the sugar. The first generation products include high and low molecular weight dextran. The second generation are the ferric gluconate and iron sucrose. The third generation, which have now made first and second generation absolutely obsolete, includes FCM. This is the structure of third generation, or I would say almost all the safe parental iron preparation. There's a core of iron hydroxide in the center, and there's a covering. For example, here, this is a covering of ferric carboxymaltose, the FCM. FCM is usually in the form of these ribbons that you see over here, rather than a full covering with a central ferric hydroxide. What you see over here is a turbidity surrounding the well. Now, this turbidity, the bigger the diameter, more is the adverse effect of the parental iron preparation. And if you come to the last one, the FCM over here, there is hardly any turbidity. That means the adverse reactions of FCM are the least as against, say, for example, high molecular weight dextran. So overall advantages of parenteral iron, especially intravenous, is that it is always effective. There is nothing like failure. It is rapidly effective. It is relatively free from adverse events. It is so safe that no test dose is needed like the first generation iron, parenteral iron preparations. The black box warning has been removed by US FDA. There's no question of GI intolerance. The present preparation like FCM have the ease of administration where one single sitting over 15 minutes, the total calculated dose can be administered for most of the women. And hence, this is recommended treatment for the primary non-hospital setting in the clinic of a family physician, gynecologist, or internist. This makes it a very cost-effective way of administering iron because a single visit with minimum of wastage of time of the patient, the accompanying person, and the medical team. Also, timely giving parenteral iron preparation would avoid the need for blood transfusion, which is one of the most dangerous type of treatment of simple thing like deficiency anemia. Also, it reduces the requirement of erythropoietin to boost the hemoglobin, an expensive product. Let us now concentrate on ferric carboxymaltose, or the FCM. It's also called the magic bullet as far as the treatment of iron deficiency in medicine is concerned. It was almost a decade ago when the US FDA first approved intravenous FCM for adults as a course of 1500 milligram. FCM, once administered, is taken up by the reticular endothelial system in no time. And then it is delivered slowly to the iron-binding proteins, which are ferritin and transferrin. Over 80% of iron that is liberated from the RES is slowly taken to the marrow via transferrin, while 20% is stored in the body. As there is no release of free ionic iron in the body, there is minimal toxicity. This free ionic iron is called NTBI, or non-transferrin bound iron, and it is quite toxic. So this should be the least for a good parenteral iron preparation. As far as the efficacy is concerned, efficacy of FCM has been proven in multiple large studies, and within about a period of 6 weeks, your hemoglobin crosses 13 grams. And this is irrespective of the starting hemoglobin. The hemoglobin may be very low, hemoglobin may be just 10% deficient. It takes the usual same 6 weeks for the hemoglobin to become normal. If you compare with oral iron, which is shown in blue, the efficacy of FCM is superior, both at day 21, that is 3 weeks, and day 42, that is 6 weeks. So it is more effective and it is rapidly effective. Same in another study, FCM versus oral iron. Oral iron is shown in blue and the FCM is shown in red. It is more effective and more rapid. If you compare with second generation parental iron like iron sucrose, the biggest advantage of FCM is that it can be given as a single total dose therapy in 15 minutes, as against iron sucrose, which cannot be given as a total dose at one sitting. It has to be given in 3 to 7 sittings, depending upon the dose you calculate, because not more than 200 milligram can be administered in one go. And that makes it expensive, time-consuming, and elaborate treatment. And once again, if you compare the efficacy of FCM with iron sucrose, FCM is shown in the orange bar. It is superior to second generation iron sucrose. And this is the cost of therapy. In the red, you have iron sucrose. In the blue, you have FCM. And because of the repeated visits, it becomes more expensive to treat somebody with iron sucrose than with FCM. This is a very nice article published last year. Comparative efficacy and safety of IV FCM versus iron sucrose in OBGYN practice. It's a systematic review and meta-analysis. The conclusion is that the FCM group showed better efficacy in improving hemoglobin and ferritin level with a favorable safety profile, fewer adverse effects as compared to iron sucrose amongst obstetric and gynec patients. And that's what is shown here from the same study. All these second bars are FCM, and overall, the FCM has got more efficacious, is a more efficacious molecule than iron sucrose. Similar kind of study over here. This is the real study published in Medicine that I was talking about. What are the indications of parenteral iron therapy? In fact, as I mentioned last time, in past we used to say that you have to search for the indication for parenteral iron. Today, I would say the other way. All patients should be treated by parenteral intravenous iron therapy unless there is a reason to use oral iron preparations. Well, the traditional indications of IV iron therapy are somebody is intolerant to oral iron, there's inadequate response to oral iron, there's a need for rapid response, like somebody is presented to you in third trimester of pregnancy or maybe just a month before the delivery, postpartum anemia, menorrhagia, or any other type of bleeding where it is not possible to replace that much of iron by mouth, inflammatory bowel disease where oral iron can be an irritant and increase the inflammatory cytokines, after bariatric surgery because you have removed the site of absorption of iron or removed the site of where ferric form is converted into ferrous form like the stomach. The cardiorenal syndrome, we discussed this last time, and the chronic kidney disease where erythropoietin together with parenteral iron is the best way to treat the patient. And lastly, anemia of systemic disease, which I'm going to touch again today. So this is Lancet Hematology 2 years ago, 2020, intravenous iron, a framework for changing the management of iron deficiency. Conclusion is, with the advent of new IV oral formulation that allow complete replacement dosing in 15 to 20 minutes with a very favorable safety profile, physician today is motivated to consider giving a top priority to use IV iron as the treatment of iron deficiency anemia. Efficacy and safety of FCM in patients having cirrhosis with GI bleeding, and the similar kind of conclusion, FCM administered achieved optimal hemoglobin level in most cirrhotic patients with acute or chronic GI bleeding. Inflammatory bowel disease, and this is a systematic review and meta-analysis to see the efficacy and tolerability of various iron preparations in people with inflammatory bowel disease, concluding that IV iron supplementation is the best way to treat IDA in patients with inflammatory bowel disease because inflammation hampers intestinal iron absorption through enhanced hepcidin pathway. This is adverse reactions after intravenous iron infusion in inflammatory bowel disease, concluding that this is extremely uncommon. This is C-reactive protein level predicting that the patient will not respond to oral iron therapy because this is an inflammatory marker which will lead to hepcidin, which will block absorption of oral iron. This is safety efficacy of FCM in inflammatory bowel disease in routine daily practice. And the conclusion is this is effective, this is safe in a large cohort of patients. This is oral versus intravenous iron therapy. Oral iron therapy leads to alteration in the gut microbiome and metabolome, as a result of which inflammation can increase. Coming to the OBGYN. So in a gynec practice, when you've got a woman who has got uterine bleeding due to various causes, the best way to accomplish the response and give a good hemoglobin is to inject the large dose, like a gram of intravenous FCM in this patient. And that is what is the conclusion at the bottom of this study. In the obstetric, coming to the pregnancy, and there are a number of antepartum and postpartum anemia reviews. It's not a difficult slide for an obstetrician or gynecologist to understand that the global estimate of prevalence of anemia in pregnant women between 15 to 50 years is massive. In the industrialized world also, it is almost up to 20%. And in a country like India over here is to the tune of 40 to 50%. And this is a nice cartoon showing you that iron deficiency affects over 50% of pregnancy in high resource setting. US, Europe, Australia. 25% of pregnancies are complicated by severe iron deficiency. And yet 40% of pregnant women are not even screened for iron deficiency. This should be an eye-opener. And this is intravenous FCM for anemia in pregnancy. Conclusion, it is safe, it is effective. The contribution of iron deficiency to the risk of peripartum transfusion is an important study because giving IV FCM at the time when it is required, like second and the third trimester, can obviate the need to give blood transfusion after the delivery. And this is once again Lancet Global Health last year, efficacy and safety of intravenous FCM compared to oral iron in Tanzanian women, phase 3 trial, and this is in Malawian pregnant women, the revamp trial. All these studies ultimately tell you only one thing, that giving total dose IV FCM over 15 to 20 minutes, single sitting during second and third trimester can obviate the agony of iron deficiency and obviate the need for blood transfusion in peripartum period. Remember, in thalassemia carriers, which are plenty in India, during pregnancy, all become iron deficient and they need iron supplements. Safety during pregnancy. Is it safe during first, second, and third trimester? Safety during second and third trimester has been documented and it must not be used in the first trimester. That is the standard of care. And therefore, you have these kind of flow charts. And I want you to look at the pink one. So first trimester, you use oral iron therapy. And if the patient is responding, wonderful. If the patient is not responding, there is a need, give blood transfusion. Or if you can wait, then during second trimester, you can give intravenous iron. That is after 13th week of gestation. And during second and third trimester, the treatment is intravenous iron therapy, especially if the hemoglobin is below 10.5. Elderly individual. Indian population is gradually getting aged. And look at this. Once you have aged population, there is an increased incidence of anemia, which is multifactorial. There is anemia of inflammation, renal dysfunction, nutritional deficiency, and clonal marrow disorders. It's important to remember that many of these will respond to parenteral iron and not oral iron. Cardiac failure can be an important problem in elderly people, and giving FCM and maintaining hemoglobin takes care of it to a large extent. We talked about iron deficiency without anemia. Do ferritin in people who complain of fatigue and treat them, because fatigue may be the only complaint of iron deficiency. And this is single dose FCM in fatigued iron deficient women, the preferred randomized placebo controlled study. The Cochrane intravenous iron therapy for non-anemic iron deficient adults. Coming to the pediatric, now 4 months ago, FCM has received US FDA approval for pediatric patient with iron deficiency anemia. So that is another huge advantage. Child is not mini adult, and iron deficiency in infancy can be treated by iron fortification or by iron therapy. And the best way probably is to iron supplement and use fortified food items. And the number of articles showing you advances in pediatric intravenous iron therapy, intravenous FCM in children with iron deficiency who didn't respond to oral iron, intravenous FCM in patients with poor oral response, etc., etc. And this is patients, pediatric patients having GI problem receiving FCM. Okay, come to some practical issues. How long does it take to treat the iron deficiency anemia? Does it take months or days or minutes? Now, a lot of iron therapies are like you are traveling by bullock cart. If you're using oral iron therapy, you have to give it for 6 months. 2-3 months for the hemoglobin to normalize, 2-3 months for the stores to be replenished. We are in the jet age. Time is an essence. Parenteral iron therapy, as I mentioned multiple times, can be given in 15 minutes, irrespective of the dose that you have to give. And that can make a woman extremely happy. 15 minutes in your clinic and the job is done. How do you calculate the dose? The dose is calculated as 0.3 weight and the hemoglobin deficiency, 0.3 WD. So weight is in pounds and the deficiency in percentage. Give you an example, woman weighing 100 pounds, has got a hemoglobin of 8, so she's 33% deficient, normal being 12. 0.3 WD, it comes to about 1000 milligram. This 1000 milligram can be given intravenously within a period of about 15 minutes. This is a simplified scheme to calculate how much iron a woman or a man requires. It is based on what is your starting hemoglobin and what is your body weight. Majority of the people would require about 1 gram of FCM, and that can be given without any hesitation one sitting. And if you require more than that, you can give extra 500 or extra gram after 7 days. So 1 gram, 1 sitting, 1.5 gram, 2 sitting, 2 grams, 2 sittings. This is another simplified scheme. I'll not go into the details. We just keep this in front of us while looking at the calculation of FCM dose based on body weight and based on the hemoglobin level. How is it administered? As I mentioned, can be administered as a bolus, undiluted, slow bolus. 500 mg is the limit, and minimum 10 ml of volume. And minimum time taken should be 5 minutes. We don't use this much. We prefer to give it as a slow infusion. You must take care that iron does not extravasate while giving intravenously. Don't force it. If there's slightest pain to the woman, stop there. Or else there will be a pigmentation which can last for years, maybe lifelong. This is the way I use iron, as a short IV infusion, where 1 gram of FCM is put in 500 ml of normal saline. Please do not use more than 500 ml. So it is important that there is not less than 2 milligram of iron per ml, because that maintains it stable. You can use smaller amount of saline, but not more than 500 ml in any case. And it should be administered at least over 15 minutes. So 15 mg per kg can be used in one sitting. For 65 kg woman, this will come to 1 gram. Give it in 15 minutes. You can repeat it after 1 week. Second dose is necessary only if you've got a high body weight or you've got very low hemoglobin. What about the tolerance to IV FCM? Tolerance is excellent. The adverse effects are not many. 4 which are listed here are a small incidence of hypersensitivity reaction, clinically insignificant hypophosphatemia, occasional patients getting hypertension, and some getting nausea, flushing, and dizziness. There is no anaphylactic reaction. This is a picture showing you a little bit of erythema, and this is a picture showing you more erythema. This slide I've shown you already, and the darker iron is the side effects of FCM versus oral iron. And you see that these symptoms are present in just 1–2% of patients. So safety of intravenous iron preparation has been analyzed and published repeatedly. And conclusion is it is not associated with increased risk of serious adverse effects. In fact, if you look at the moderate and severe side effects, they are more with oral ferrous sulfate than with IV FCM. Hypersensitivity reaction has been fully analyzed. This is not IgE mediated. This represents what is called CARPA. No test dose is needed, but caution is needed that each time you give intravenous iron, you must be careful that reactions are not occurring. There are studies to show you how to prevent and manage acute reactions, etc. And this is an important study showing you that the hypersensitivity reactions are more common with isomaltosite than with FCM. FCM is associated with 75% lower risk of hypersensitivity reaction when compared with iron isomaltose 1000. Does intravenous iron cause infection? Majority believe no, but this probably is an unanswered question. This is an Israeli study about the intravenous iron formulation, once again telling you same thing that we have been talking about. Hypophosphatemia, it occurs, no doubt. It occurs more common in children, no doubt. It is because of a complicated pathway which is through FGF23, and there are a lot of methods of explaining this. But the beauty is that this is a laboratory phenomenon. It does not produce clinical event, and hence we don't bother to estimate phosphorus levels after this. So overall, intravenous iron is more effective, better tolerated. It must be used when there is bleeding, late pregnancy, GI intolerance, impaired absorption, irritable bowel disease. These are absolute indication for intravenous iron. Remember, there is a cause for iron deficiency sometimes, and that cause must be treated. I don't have time. I did this last time. There are large number of conditions where the availability of iron could be poor. There may be physiological increase requirement of the iron, and there may be blood loss. In all these conditions, it's important to treat the underlying cause. And I talked about bariatric surgery, the new cause of iron deficiency must never be forgotten. Also, not all microcytic anemia are iron deficiency, and we discussed it last time. This is a complicated slide, but what it tells you is remind you that microcytic anemia has got more than one causes, like thalassemia, like what we talked last time about iron refractory iron deficiency anemia, the temperance. Lastly, a word about chronic diseases. And I'd like to show you this case and close my presentation. Woman with 8.5 grams of hemoglobin, microcytic, she had recurrent UTI. The workup showed this was anemia of systemic disease and not iron deficiency. What happens here is the hepcidin levels are high, iron is trapped. It doesn't go to the bone marrow. So hepcidin is extremely important in blocking. This is the concept of functional iron deficiency. A lot of iron in the macrophages, but nothing going to the bone marrow. This can happen with tuberculosis. This can happen with UTI. This can happen with rheumatoid arthritis. This can happen with cancer. This can happen with chemotherapy. In all these conditions, you have hepcidin, which is high. Oral iron is not absorbed, and you need then to give parenteral iron therapy, sometimes maybe together with EPO. But anemia of chronic disease, anemia of systemic disease, anemia of inflammation, anemia of cancer, anemia of chemotherapy requires parenteral iron therapy. So I conclude my talk by saying that there are ways and means of treating anemia, from dietary advice to blood transfusion, both of which are either ineffective or dangerous. Oral iron to parenteral iron, and I showed you why parenteral iron is the best way to replace iron. Intramuscular and IV, and I showed you that intramuscular is obsolete. And in intravenous preparation, the third generation preparation with extreme safety is ferric carboxymaltose. So that is today the commonest of the prescription all across the world. 1 gram of iron, and if you need more, another half gram or 1 gram after 1 week. Whatever I spoke today is probably a drop in the ocean. You can read and read more about it and become more and more knowledgeable. That's all for the day. Thank you so much for giving this opportunity to me to speak to you.
Thank you so much, sir, for that comprehensive and a very informative session on intravenous iron with focus on ferric carboxymaltose. It has been a very enlightening session. So we have received a few questions from the delegates. So I'll just present the questions to you, sir. So one of the participant has asked, what is the recommended interval between two FCM infusions, if at all it is required?
1 week.
Okay, so 1 week. Okay, thank you, sir. Sir, we have received many queries on this aspect, so I'll just summarize it. So most of the participants say that they have observed mild like adverse effects like urticaria and rashes with IV iron. So what could be the line of treatment for such adverse effects, if at all seen?
Sure. I mean, this happens in about 2 to 5% of patients. Antihistaminics is the usual treatment, sometimes with paracetamol and very rarely with corticosteroids.
Okay, sir. So one question, sir. So you said that in thalassemia carriers, there is a requirement of iron supplements. So how intravenous iron can be used in the treatment of iron deficiency of thalassemia carriers? Is there any way for this?
Yeah, so thalassemia minor gives you no protection against iron deficiency. So if you have got thalassemia minor and if your hemoglobin was say 10, 11, during pregnancy, if you do not replace iron, your hemoglobin will drop. And this drop is more than what happens due to hydremia of pregnancy itself. And if you do iron studies during second trimester, all pregnant women with thalassemia minor, ferritin is low, transferrin saturation is low, TIBC is high. They all need iron supplement. And as I said, the best way to give iron supplement during pregnancy is intravenous FCM, 15 minutes, one shot.
Thank you, sir. So again, we also have received that, is it means you have highlighted this aspect in your presentation more than once, but still we have received questions that is it safe to administer 1000 milligrams in like 15 minutes of short duration?
Absolutely, 15 milligram per kg. So unless your body weight is very small, it can happen. I mean, somebody is 25, 30 kilo, that can happen, but average Indian woman is 50 kg plus. So 15 milligram per kg will come to 750 milligram for that lady. The moment you are about 65 kg, then you can easily, very comfortably, with a recommendation, international recommendation, you can give 1 gram. So most of the women who are 65 kg, I give 1 gram in one go. The duration is 15 is the minimum. Okay. If a woman wants to take it over half an hour, 1 hour, 2 hours, there is no adverse events except wasting time. So if you are concerned about this 15-minute business, you can give it in 20, 25, 30, 40, 50 minutes. You must not give it in less than 15 minutes. That is what the 15-minute business means.
Understood, sir. So thank you for that answer, sir. So can we take one more question, sir?
As many as you want, I'm free.
Yes, sir. So, sir, a few questions are related, like can IV FCM be used in ICU patients? And if the patient is in septic shock, can it be used?
So I did show you a slide that there is a controversial issue whether intravenous iron therapy increases infection. Yes. There are some studies in the neonates which have tried to show that the incidence of septicemia in neonates was a bit higher when they received intravenous iron preparations. But in the same picture that I showed you, I showed that this is a controversial issue. And the last statement has not been made. So I'm not much concerned about adult patients who got infection. And if you need iron therapy, giving them intravenous FCM. Patients with miliary tuberculosis, patients with sepsis, patients in ICU. We have used, as you know, in ICU, as such, oral preparations are difficult to administer. Many are unconscious, many have got Ray's tube, and it's a difficult business. So I personally am not convinced that this causes much of infection. And fortunately, I'm not a neonatologist, so I don't handle them. But except probably that neonatology business, rest of the people, I don't think should be worried at all.
Okay, sir. So another question is that can FCM be used in a patient of DVT who has iron deficiency anemia?
So remember that thrombosis in anemia is related to high hepcidin level. I passed through that slide because I thought I may fall short of time. In fact, I finished my talk in 35 minutes, so I had time to discuss this issue. It is related to high levels of hepcidin and not related to anemia. So anemia is not a prothrombotic disorder. Nothing to worry at all. So FCM does not cause thrombosis. You've got iron deficiency, you've got DVT, you're giving patient anticoagulation, you can give FCM. We've done that left and right.
Okay. So I guess those are the questions from the one more question that in malaria endemic areas, what is the for can FCM be used in the malaria endemic areas? So the question is not that clear. I am not sure the.
Oh, well, I can make it clear. So
Yes.
as I told you that when you've got infection, inflammation, you produce a lot of hepcidin, and that blocks the iron absorption from the oral route. So anemia of infection, whether it's malaria, whether it's tuberculosis, whether it's urinary tract infection, whatever it may be, anemia of infection, anemia of inflammation like rheumatoid, SLE, anemia of cancer like metastatic CA ovary, anemia of chemotherapy or anemia of radiotherapy, all these conditions hepcidin levels are high. So in last 10 years, we have understood this very well that oral iron does not work in all these conditions. The best way is to give IV FCM, and in some of these conditions, you require together with erythropoietin. Two together, your hemoglobin, which is stuck at 7, can go to 10, 11 grams.
Thank you for that answer, sir. In the last lecture, you had said that you'll elaborate on the hepcidin block and how it has changed the paradigm from the oral iron to the intravenous iron. And I believe that we have done that in a very effective manner in this lecture, sir. Thank you very much for that. With this, I conclude the question and answer session. And that brings us to the end of this lecture series. I, Dr. Ajinkya Rodge, on behalf of the entire Emcure team, once again, thank you from the bottom of my heart for this very informative and enlightening lectures on diagnosis of anemia and management of anemia with focus on FCM. We are very thankful to you, sir. And I'm sure all the participants who have joined both the lectures, and they must have benefited a lot from these lectures, sir. So I thank you once again, and I thank all the participants who joined the session and took the most benefit of this opportunity to have such wonderful lectures from Dr. M.B. Aggarwal, sir. Thank you, sir.
Thank you so much. Bye-bye. Good night.
Good night. Nishat, we can go off the live cast.
Yes, sir. Done. Done, sir.
Good
Should
night.
I end the meeting?
Live streaming is off.